This recorded lecture will be going over Chapter 15, Drugs Affecting the Hematologic System, in the Evolve Introduction to Clinical Pharmacology textbook. Drugs that affect the hematologic system work by interfering with blood clotting, reducing existing blood clots, or stimulating the production of red blood cells. A clot is a semi-solid amount of coagulated or thickened blood that will block blood flow in a blood vessel. Blood circulates to all tissues and organs continuously and forms clots only when and where they are needed. Any tissue damage will start a series of reactions to protect the body and repair the injury. Thrombin is an enzyme that acts on fibrinogen, a protein found within blood plasma, converting it to fibrin and form a net-like substance in the blood that will trap blood cells and platelets to form the matrix or frame of a blood clot. An embolism is a blockage in an artery caused by a blood clot or an air bubble. An anticoagulant is a drug that interferes with one or more steps in the blood clotting process. These drugs can reduce or prevent new clots from forming and help to prevent existing clots from getting larger. They cannot dissolve to form clots. Anticoagulants are mistakenly called blood thinners, but they don't actually thin the blood. Drugs that act as anticoagulants can be classified as platelet inhibitors, direct thrombin inhibitors, indirect thrombin inhibitors, or vitamin K antagonists. On page 279 within table 15.1, you can read more about the different types of anticoagulants. Platelet inhibitors, also known as antiplatelet drugs, will interfere with the blood clotting in arteries by preventing platelets from sticking and clumping together to form a platelet plug. Platelet inhibitors will work in the cardiovascular system to prevent clotting events in a patient who may have reduced blood circulation to the heart before an MI. Common platelet inhibitors include aspirin, clopidogrel, dipyrimidine, epifitabide, prasugrel, ticlopidine, tirofiban, and silotazole. Platelet inhibitors are often the first drugs used to prevent clots within the blood vessels. These drugs will often be given prophylactically when a patient has a condition that could produce blood clots to prevent further extension of the clot or to prevent further development of blood clots. These drugs can do nothing to dissolve the clots that have already developed. They can be given as additional drugs or adjuncts to thrombolytic therapy to patients who have had a heart attack to prevent them from having another one. Acetylsalicylic acid, or aspirin, is the most commonly used antiplatelet drug. Aspirin reduces the risk of major blood vessel blockage that can lead to acute MI, ischemic stroke, angina, and peripheral arterial disease. It will also carry the risk of GI bleeding in older adult patients, in those with a history of peptic ulcer disease, and in patients using NSAIDs or more than one antiplatelet therapy. Clopidogrel, or Plavix, can be given to patients who have had an MI caused by a clot formed in a coronary artery. In patients who have had a stent placed into the coronary artery as a result of severe narrowing or blockage of that artery, Plavix will prevent platelets from sticking to the stent mesh. For these patients, Plavix must be taken daily for a year or longer to prevent clots from developing and plugging the stent. It can also be used in patients with PAD to prevent blood clots in the legs, for prevention of an MI, and as an additional therapy along with thrombolytic drugs to prevent additional strokes after a recent ischemic stroke. Most drugs that affect the blood clotting system have the potential to cause bleeding, especially when used in combination with other antiplatelet drugs. Easy bruising is common. For example, bleeding of the gums could occur when the patient brushes their teeth. GI effects like diarrhea, nausea, dyspepsia, vomiting, flatulence, and anorexia have been experienced. Skin effects like a rash, pruritus, and purpura have all been reported. Excessive bleeding, including acute hemorrhage, is the most common adverse effect. Allergic reactions to aspirin and NSAIDs will typically occur within a few hours after taking the drug. Symptoms of an allergic reaction include hives, itching, and runny nose, with more severe reactions causing swelling of the lips, tongues, or face. New acute cardiovascular events can occur when these drugs are stopped abruptly. Therefore, they should never be discontinued without the advice of the patient's healthcare provider. Some of these drugs, including Plavix, can decrease the platelet count, known as thrombocytopenia, and the white blood cell count. Anticoagulants have many interactions with other drugs and foods that can all increase the risk of bleeding or decrease the effectiveness of the drug. Platelet inhibitors like aspirin and NSAIDs, if taken with other drugs that reduce coagulation, can lead to excessive bleeding. Drinking alcoholic beverages can increase the risk of bleeding due to their effect on the liver, where some clotting factors are formed. Other drugs like vitamin K and oral contraceptives will decrease the effects of the anticoagulants. Some drugs that protect the GI system, like proton pump inhibitors, can interact with Plavix and decrease its effectiveness. Green leafy vegetables contain vitamin K, and they can decrease the effectiveness of anticoagulants. Many herbal products, vitamins, and supplements can interfere with anticoagulants. For example, St. John's wort will further increase the risk of bleeding if it is used by someone taking an anticoagulant. Before giving the first dose of any platelet inhibitor, it is important to ask the patient what other drugs they have taken within the past week, including any over-the-counter drugs, vitamins, minerals, or herbal products. Ask whether the patient currently has any bruising or bleeding, especially from the gums, nose, or mouth, which could be a sign of low platelet count and increase their bleeding risk. Assess for signs of internal bleeding, such as severe abdominal pain and tenderness, vomiting or diarrhea that contains frank red blood or is coffee colored, or any cold, clammy skin. Give platelet inhibitors and record the doses given as well as the patient's response. Tachycardia and hypotension can occur with bleeding, so monitor the pulse and blood pressure at least once per shift. Changes in vital signs and the levels of consciousness can all provide important feedback about the possible risk of bleeding that could occur with these drugs. Determine whether the patient understands why they are taking the drug and the symptoms of overdose. Have the patient report any signs of bruising or easy bleeding. All direct thrombin inhibitors prevent the formation of blood clots, or thrombi, by interfering with the activity of the enzyme thrombin, or factor II. This action will increase the time it takes for the blood to clot, preventing new clots from forming. These drugs will not dissolve clots that have already formed. All of these drugs will stop the coagulation cascade by binding to free thrombin in the blood and to thrombin that is bound to fibrin. DTIs are used to prevent clots in arteries and veins. They can also be used to prevent and treat DVT or pulmonary embolism, or to prevent clotting from atrial fibrillation. The advantage of DTIs is that they do not require frequent lab blood testing as part of the monitoring process that is typically required for warfarin. DTIs can cause bleeding. Easy bruising is common, including bleeding gums when the patient brushes their teeth. Another common side effect of DTIs includes gastric upset when the drug is taken on an empty stomach. By far, the most common adverse reaction from DTIs is excessive bleeding and thrombocytopenia. Early signs of overdose or internal bleeding would include bleeding from the gums while brushing the teeth, excessive bleeding or oozing from cuts, unexplained bruising or nosebleeds, and unusually heavy or unexpected menses in women. These are must-know signs and symptoms that will indicate when the patient needs prompt attention. DTIs can interact with many commonly prescribed drugs and some supplements, including atorvastatin, azithromycin, carvedilol, clarithromycin, cyclosporin, diltiazem, and St. John's wort. When they are taken together, the concentration of DTIs increases, which greatly increases the risk of excessive bleeding. When taken with carbamazepine, dexamethasone, phenobarbital, phenytoin, or rifampin, the concentrations and actions of DTIs will be reduced, therefore decreasing their effectiveness. Antacids can also reduce the actions of DTIs. Assess your patients for any of the following symptoms, which could be a sign of serious bleeding: unusual bruising, blood in the urine, stool, or vomitus, coughing up blood, headache, dizziness, or weakness, recurring nosebleeds, unusual bleeding from the gums, or menstrual bleeding that is heavier than normal. Teach your patient and family members to take DTIs on time. Accidental overdose could lead to excessive bleeding. If needed, the reversal agent, which is idarucizumab, can be prescribed by the healthcare provider. Teach patients and family members not to discontinue their DTIs without talking to their healthcare provider who prescribed it due to the risk for serious clotting events increasing. Instruct your patients to keep DTIs in the original bottle to protect it from moisture and light. Teach patients not to chew or break the capsules before swallowing them because the drug may be absorbed too rapidly or destroyed by stomach acid. Watch for any signs of overdose and internal bleeding. Teach your patient and family the following. Take DTIs on time. When a dose is missed, take it as soon as possible on the same day, but if there will be less than 6 hours before the next scheduled dose, the missed dose should not be taken. Accidental overdose can lead to excessive bleeding. Do not discontinue a DTI without talking to your healthcare provider. Keep DTIs in their original bottle to protect the drug from moisture and light. Do not chew or break the capsules before swallowing because the drug could be absorbed too rapidly or destroyed by stomach acid. Take DTIs with a full glass of water to prevent stomach irritation and improve absorption. Indirect thrombin inhibitors are anticoagulant drugs that reduce clot formation by increasing the amount and action of the protein antithrombin 3. This protein will inhibit thrombin from converting fibrinogen to fibrin in the blood, reducing clot formation. Heparin can be given only by injection because it cannot be absorbed orally. Low molecular weight heparin is a special formulation of heparin that has a steady anticoagulation effect compared to unfractioned heparin sodium. The half-life of LMWH is longer than that of heparin sodium, ranging from 2 to 4 hours after IV injection to 3 to 6 hours after subcutaneous injection. Therapy with heparin sodium must be monitored for its anticoagulation effect. We do this by a blood test known as the activated partial thromboplastin time, or APTT. The prescriber will maintain or adjust the dosage according to the test result. The LMWH formulation does not require any testing. Heparin is used to prevent formation of new clots or to stop existing clots from growing in size. Heparin therapy can be used prophylactically during and after many types of surgery, especially any surgery involving the heart or circulatory system. Any patient who is on bed rest for a long time is at risk for blood clots, especially any patient with a history of clotting problems or a recent orthopedic, thoracic, or abdominal surgery. LMWH is used especially in the prevention of venous thromboembolism, and it can be used when a pulmonary embolism is present. Heparin sodium can cause easy bleeding and bruising, pain, redness, warmth, irritation, or skin changes where the drug was injected. Other side effects could include foot itching and bluish-colored skin. Adverse reactions would include hemorrhage, thrombocytopenia, shortness of breath, wheezing, chills, fever, alopecia, and hypersensitivity reaction. In cases of heparin overdose, protamine sulfate should be given to counteract the effect of heparin. Serious adverse reactions include heparin-induced thrombocytopenia and heparin-induced thrombocytopenia and thrombosis. If major clots develop and block vessels, the condition is even more serious, and it is then called HITT. Heparin can interact with aspirin, NSAIDs, glucocorticoids, and other anticoagulants to increase the risk of GI bleeding. Antihistamines, digoxin, nicotine, and tetracycline will all decrease the anticoagulant effect of heparin. Heparin is derived from animal tissue and is more likely to cause an allergic reaction than other anticoagulants. This drug should be used cautiously in patients with liver or kidney disease, or hypertension, during menses, after delivery, and in patients with indwelling catheters. Dosages for heparin will be given in units. Heparin is only given by IV injection, IV infusion, or subcutaneous injection. Do not shake the bottle containing the heparin. Instead, roll it carefully between your hands before you insert the needle. Heparin is strongly acidic, and it is incompatible with many other drugs within a solution. Therefore, it must not be piggybacked with any other drug into an infusion line. You must never mix any drug with heparin within a syringe when administering a bolus dose. For a subcutaneous injection, it should be given in the abdomen around the umbilicus. After the needle has been inserted into the patient, do not attempt to pull back on the plunger or aspirate any blood before injection. Do not move the needle while the heparin is being injected, and do not massage the injection site before or after the injection. Doing any of those actions could increase tissue damage from the heparin. Rotate the sites of your subcutaneous injections to avoid the formation of any hematomas. Double-check the dose drawn up with another nurse prior to giving it because of the adverse effects if the inaccurate dose is given. If intermittent IV therapy is prescribed, you should draw blood for partial thromboplastin time, or PT, determination about 1 hour before the next scheduled heparin dose. Blood should never be drawn from the tubing of the heparin infusion line or from the same vein being used for the infusion. Instead, the blood should be drawn from the arm not being used for the heparin infusion. Continuous IV therapy with heparin can first be started with a bolus of heparin based on the weight of the patient. Obtaining an accurate weight is very important before initiating heparin therapy. Heparin is typically started for an immediate effect and gradually replaced by oral anticoagulants. The most commonly used blood test for determining the therapeutic range for heparin is the APTT. The dosage of heparin is considered adequate when the APTT is about 1.5 to 2.5 times the laboratory control value. PT and International Normalized Ratio, or INR test, are ordered when the patient is started on an oral anticoagulant and then at regular intervals thereafter. The normal range for the INR is 0.8 to 1.2, with a therapeutic target range of 2 to 3. When the oral anticoagulant shows proper effect and the prothrombin activity is within the therapeutic range, the heparin therapy can be discontinued and the oral anticoagulant therapy continued. Be sure that the heparin antidote, protamine sulfate, is available for use when patients are given heparin therapy while hospitalized, just in case of accidental overdosage or an acute bleeding event. You need to urgently contact the appropriate healthcare provider for an order before giving the protamine sulfate. Be sure that the heparin If heparin is given by continuous IV infusion, the coagulation time should usually be determined every 4 hours in the early stages of treatment. Watch for any signs of allergy, as well as any signs of overdose and internal bleeding as the therapy progresses. Check with the patient and their family to ensure that they understand the dosage schedule, any side effects, adverse effects, and which signs of adverse reactions to report to the healthcare provider. These signs would include bleeding gums when brushing the teeth, blood in the urine, and coughing up blood. A vitamin K antagonist is an anticoagulant drug that interferes with blood clotting by reducing the amount of vitamin K available to help the liver form clotting factors. The most common drug in this class is warfarin. Vitamin K antagonists will inhibit the enzyme needed for final activation of vitamin K. Blood clotting requires the actions of all of the clotting factors, and limiting any of the clotting factor will reduce blood clot formation. For long-term therapy in chronic conditions that could involve problems with clot formation, warfarin will be the drug of choice. Patients will typically begin warfarin when taking heparin. Heparin can then be discontinued after the INR result for blood clotting time reaches a therapeutic range. Easy bruising and bleeding with warfarin is common. Warfarin can produce GI upset, headache, and rash. Adverse reactions of warfarin include excessive bleeding and hemorrhage that can occur with very heavy menstrual bleeding, frank blood or dark tarry stools, or coffee-colored vomitus with excessive dosage. Warfarin can cause skin necrosis, which can occur within the first 10 days of therapy and is associated with larger doses. Warfarin is not given during pregnancy because it could cause birth defects or death of the fetus. In response to some bleeding disorders or warfarin overdosage, a synthetic, human-made form of vitamin K, known as phenotadione, can be given orally or parenterally to help stimulate the liver to resume manufacture of prothrombin and to serve as an anticoagulant antagonist. Blood products that contain clotting factors may have to be given to stop any severe bleeding. Vitamin K antagonists will interact with many other drugs. In general, many antibiotics, anti-inflammatory drugs, antidysrhythmics, GI drugs, statins, and steroids can lengthen the bleeding time due to warfarin, whereas antacids, antihistamines, barbiturates, large doses of vitamin C, and oral contraceptives can shorten it. Vitamin K antagonists will also interact with many herbal preparations and supplements, and patients should consult with their healthcare provider before they begin any of these while taking this drug. Anticoagulant effects can be increased with acute alcohol intoxication, but will be decreased with chronic alcohol abuse. Green leafy vegetables are a natural source of vitamin K, and they can decrease the effect of anticoagulants. Ask about any conditions that would prevent the use of some anticoagulants, like alcoholism, blood diseases, and conditions associated with bleeding, and uncontrolled hypertension. Make absolutely sure that female patients who are taking a vitamin K antagonist are not pregnant or breastfeeding. Warfarin has a very narrow range that produces the anticoagulant effects without also causing bleeding in the patient. Frequent blood tests will be done to monitor bleeding risk while still providing the anticoagulation needed. The INR will be used to standardize PT reporting. In a person who is not receiving anticoagulation therapy, the normal INR is 0.9 to 1.1. The typical INR goal for a patient who needs anticoagulation therapy is 2 to 3, except in cases of mechanical cardiac valve replacement, in which a higher INR may be necessary to prevent the clot formation. Initially, the PT-INR can be measured daily, but after stabilization, tests can be performed at 1 to 4 week intervals, depending on patient response. The antidote for warfarin overdosage, vitamin K, should be available at all times. Warfarin takes up to 72 hours before it reaches an effective level for anticoagulation. Watch for any signs of overdose and internal bleeding as the therapy progresses. Have the patient explain the actions that they would take if any bruising or easy bleeding were noted. Teach your patient and family the following. Wear a medical alert bracelet or carry an identification card indicating the use of an anticoagulant. Teach patients and family members about warfarin and tell them to immediately report any expected side effects and adverse reactions to the healthcare provider. Avoid adding any drugs, herbs, and supplements without the express permission of the healthcare provider. Swallow the tablets whole without cutting, crushing, or chewing them to ensure proper drug absorption. Protect the drug from humidity and light exposure because the drug's activity will be reduced by exposure to light and moisture. Avoid increasing the intake of green, leafy vegetables because they contain vitamin K and can decrease the effectiveness of warfarin. Avoid alcohol while taking warfarin because alcohol ingestion will change the drug's activity. Keep all appointments for laboratory tests. Use caution when brushing the teeth, trimming nails, and shaving. An electric shaver should be used whenever possible. Apply pressure to stop bleeding from accidental cuts or scrapes. If bleeding persists after 10 minutes, contact your healthcare provider. Do not suddenly stop taking any oral anticoagulant. Avoid contact sports or other activities that could lead to injury. At least 2 days is typically required to recover blood clotting ability after anticoagulation has been stopped. Fibrinolytic drugs, formerly called thrombolytic drugs, actually do dissolve and break down existing blood clots. For this reason, they're sometimes called clot busters. Fibrolytic drugs work by converting plasminogen to the enzyme plasmin, which degrades or breaks down fibrin clots, fibrinogen, and other plasma proteins. These drugs are only used in a critical care setting. Fibrinolytic drugs are used in acute care settings like emergency departments and intensive care units. The drugs are given for a variety of reasons, including acute MI, acute pulmonary embolus, acute ischemic stroke, and acute arterial occlusion. These drugs will dissolve clots and emboli, ultimately reducing the extent of cellular damage due to arterial blockage. Timing is a critical factor for the use of these drugs. If fibrinolytics are begun within 12 hours after a heart attack or 3 hours after the onset of a stroke, the blood clot blocking the artery can be dissolved and blood flow restored. These drugs are high alert drugs, and they will be given through an IV line. Bleeding is the most obvious side effect of fibrinolytic drugs. Low blood pressure could also occur. You can read more about fibrinolytic drugs on page 288 within Table 15.2. Allergic reactions and hypersensitivity can occur. Hemorrhage is the most critical adverse reaction that can occur, and because these drugs break up clots, there is a risk of stroke, especially in older patients with hypertension. Contraindications for giving fibrinolytic drugs include a known history of bleeding disorders, pregnancy or recent delivery, stroke within the past 2 months, hypertension with blood pressure greater than 200 over 120, head trauma, and aortic dissection. Giving fibrinolytic drugs together with other anticoagulants will increase the potential for bleeding and hemorrhage. Fibrinolytic drugs are given by the healthcare provider or advanced practitioner in the life-threatening situations of MI or stroke. They are most helpful when given within the first hour after the onset of symptoms from thrombosis. Ask whether other drugs like aspirin have been taken. Fibrinolytic drugs come as a powder that requires reconstitution. Carefully monitor and record the vital signs of a patient receiving fibrinolytic therapy. After the fibrinolytic drug has been given, do not remove IV lines or give IM injections due to the increased risk of severe bleeding. If an IV line must be removed, apply pressure to the area for 30 minutes. More significant bleeding will indicate overdose and can be shown by hematuria, hematemesis, abdominal pain and swelling, tachycardia, tachypnea, and hypotension, all of which can indicate internal bleeding. Teach your patient and family the following. Ensure that the patient and family understand the purpose, risks, and benefits of fibrinolytic therapy. Teach the patient to report to the healthcare provider any unusual symptoms, signs of an allergic reaction to the drug, or unusual bleeding. An erythropoiesis stimulating agent, or ESA, is a synthetic form of the hormone erythropoietin, which stimulates the bone marrow to make more red blood cells at a faster rate. On page 289 within table 15.3, you can read about some erythropoiesis stimulating agents. The synthetic forms of erythropoietin will work just like the natural hormone. ESAs can come in vials or in pre-filled syringes. They will be given by IV or subcutaneous routes. ESAs are usually given to patients who have a condition that causes anemia and need to increase the production of red blood cells. This would include patients with chronic kidney disease, patients who are anemic due to the effects of chemotherapy, or who may be anemic before surgery. These drugs can reduce the need for transfusions, and reduce the complications of transfusions, like fluid overload. Pain at the injection site is the most common side effect of ESAs. Generalized body aches and pain, rash, redness, or warmth at the injection site can occur. As red blood cell production increases, the blood becomes thicker. This could increase the risk of hypertension, blood clots, stroke, and MI. There is also a risk of severe allergic reaction to ESAs. Report the finding of hypertension, which may need to be controlled before ESAs are started. Ask about the presence of latex allergy, because the covers of pre-filled syringes will often contain latex. Notify the healthcare provider if the hemoglobin concentration is 12 grams per deciliter or higher before giving an ESA. Monitor the patient's iron status. This can be indicated by transferrin or serum ferritin levels, and notify the healthcare provider of the results before beginning ESAs. Do not give IV ESAs with any other drug. Do not expose the ESA vial to light, and do not shake the vial. Give the subcutaneous injections in the outer area of the upper arm, the abdomen, the front middle of the thighs, or the outer area of the buttocks. Report any signs of allergic reaction, as well as any signs of stroke, chest pain, or shortness of breath, or increases within the patient's blood pressure. Teach your patient and family the following. Weigh yourself daily and report a weight gain of 2 pounds in 24 hours or 4 pounds in a week to your healthcare provider, because these drugs could cause water retention. Go immediately to the nearest hospital if you have chest pain, because these drugs will increase blood thickness and raise blood pressure, which can increase your risk of a heart attack. Inform your healthcare provider if you are pregnant, breastfeeding, or plan to become pregnant. Iron, folate, and vitamin B12 are all needed for red blood cell production. Iron deficiency anemia will develop when there is not enough iron available for maintaining tissue oxygenation, and the body's supply of stored iron gets used up. Signs of iron deficiency anemia include weakness, shortness of breath, palpitations, tachycardia, and pale skin and mucous membranes. Iron products can be used to provide additional iron that is needed for producing hemoglobin and restoring the body stores of iron. Oral iron supplements are the most common treatment for iron deficiency anemia due to their established safety profile, ease of administration, and low cost of therapy. On page 290 within table 15.4, you can read about drugs for iron deficiency anemia. Ferrous sulfate is an iron supplement that is given orally for the treatment of iron deficiency anemia. When given orally, ferrous sulfate is absorbed in the small intestine. Ferrous sulfate is used to replace iron stores in patients with iron deficiency anemia. The most common side effects of ferrous sulfate are constipation, dark stool color, GI irritation, and nausea. If an oral solution is given, temporary discoloration of the teeth can occur. Iron overdose can lead to fatal poisoning in children younger than 6 years of age. Assess the results of the patient's CBC, especially their hemoglobin level, and notify the healthcare provider of these results. You can expect a rise in hemoglobin levels after about 3 weeks of treatment. Give ferrous sulfate on an empty stomach or 2 hours after a meal for best absorption of the drug. Avoid giving ferrous sulfate with antacids because antacids will decrease the effectiveness of the drug. Report signs of hypersensitivity. Report signs of severe anemia like tachycardia, chest pain, or shortness of breath. Teach your patient and family the following. Take the oral tablet with a full glass of water. Avoid lying down for at least 10 minutes after taking the tablet. If using the enteric-coated extended release form of ferrous sulfate, do not crush or split the tablet. If you are taking the oral liquid solution form of ferrous sulfate, shake the bottle well before each dose given. Take the solution through a straw to prevent staining of the teeth. Iron dextran is another form of the iron mineral that is essential for many body functions, especially the transportation of oxygen in the blood. Iron dextran is given by slow IV infusion or by IM injection. IM injection should